Thank you, Murli, and really a lot of thanks for having such a nice IC course, the Midas, such as you have called it. It's a real pleasure to join this, and many of these things have been covered by the previous speakers. I may just highlight them. I don't know why this is jumping. So first of all, the incisions. What has changed, first of all, is the fact that we need to do a timely adjustment. And now we are saying again and again, we are not strabismus surgeons, but we are restoring binocular vision and stereopsis. This is also important for claiming insurance, that we do not just say that it's a cosmetic surgery. I don't know why it's jumping, so I think there's some problem. Coming to the incisions, the conjunctival incisions, I think initially Dr. Vaishnavi had shown a schematic diagram. The MIS, or the minimally invasive strabismus surgery described by Mojon and Mojon, is there. We need to be, this is jumping actually. So in this, as Mojon himself has described, that you need to relearn the transconjunctival suturing trasu technique. Otherwise, there will be a lot of problem. In this, you have to actually go forth and backward. This is a special technique that you need to learn. And in spite of this, the age which he has recommended is to be used is only 14 to 40. So there are lots of reservations. So I would rather say that one should miss the miss. The adjustable surgery has been talked about very nicely. There's some problem, I think I'll just see. So as I said, in the adjustable surgery, we do a hemi hangback in order to prevent a forward creeping. And we always usually prefer the technique as also shown by Dr. Arun, that we'll be using a 1.5 knot technique. And in the video, you can see that the steps are shown, that we will be marking at the point where we want the muscle to be there, but pass the needle, and this also gives us the widening of the muscle stump. You can start there and then come more into the center. So this ensures that there is no bunching of the muscle that we want, and also the creeping forward is prevented. And then there is a silk suture which is placed in between the sclera and the first knot. So this helps us in releasing the suture at the time of adjustment, which sometimes can be tricky. And another thing which I was suggesting was that, as I learned from Dr. Rosenbaum, that you can use the bucket handle suture. And at the time of surgery, you should check that the sutures are passing easily backward and forth. This is that bucket handle suture, which we can pass with the 6-0 Weichel suture. And this will help us in holding the globe easily. And when you close the conjunctiva, you can let the sutures come through the central exposure as this, and just put the sutures on the side. So there are various techniques which you can use, either the 1.5 knot or the slip knot. Just like in COVID, we have the mask to do the sliding noose as well as the 1.5 knot. Just an example to show, this was a case of abducens palsy with bitemporal hemianopia. And it was very critical in him to adjust, because he wanted the esotropia to be corrected, which was 45 prisms, but he also had a bitemporal hemianopia. So if we had a slight overcorrection, he would complain of diplopia. So in this case, I did the LR plication of 8 and the medial rectus recession adjustable on 6 mm, and we found that we had to bring it forward to 3.5 mm. Now, such patients who are very critical or tricky, you need to have an adjustable procedure. Strengthening procedures, the resection is the technique which is mostly used, but nowadays I think the plication is now replacing for us most of the time, the medial rectus particularly. You can do a plication, and most of you may have seen this video on the YouTube, and it's a very simple procedure which can be done. This is showing you the medial rectus being hooked through the fornix approach, and then the medial rectus is exposed, the intramuscular septum is dissected on either sides, and about 8 to 10 mm separation, and then you mark it. The marks are the same as you would have planned for your resection. No different measurements have to be taken. And once you have passed these two interlocking bites with the 6-0 vicryl suture, because it's a strengthening muscle, you need to be sure that the muscle is nicely in your grip. And then just in front of the insertion, and this muscle, sclera muscle. Now this is what I call as the reinforced plication. This is important that it prevents the regression effect which people have reported. And then it nicely, you can see it can fold on an iris upholster. For the near distance disparity, we have convergence access tackled by the Farden operation or the posterior fixation on the MR. But for the lateral rectus, since the Farden doesn't work on the lateral rectus as good, we have used the combined resection recession technique on the same lateral rectus. And this is the So here it's actually simple. What you are doing is on the lateral rectus, you are marking the resection, and that component you are going to resect. You just need to plan how much resection and how much recession. Now this is X and Y, and this we have mentioned as a formula you can use on the basis of the preoperative deviation and the effect that you want on the lateral side, that it should have an incompetence created, or for the distance that you want to create lesser effect on the lateral rectus. So this is the resection part. And then, so if it is done, then the recession may be more than this part. If it is the same amount as the resection, it will give you an effect of an adjustable Farden as described by Alan Scott. So here it may be 2x the Y, and that will give you the added effect of weakening the lateral rectus. The added Y is giving you the effect on the primary deviation correction, and this Farden component gives you the effect on the abduction or for divergence axis. For the inferior obliques, I think nicely covered by Dr. Murli. I wouldn't like to go into any more details. Just to tell you about the anterior nasal transposition as was being asked. Now this video is a small video on the anterior nasal transpositioning. The inferior oblique, as it was disinserted for any other modified iliac nankin or any procedure, the same way you do it. But now you hook the inferior rectus and unroof the conjunctiva on the inferior rectus. Intermuscular septum on the nasal side of the inferior rectus is nicely separated, and this area is cleaned. Now you can get the inferior oblique just crossing over underneath the inferior rectus or inferior to the inferior rectus. And now 2 millimeters nasal and 2 millimeters posterior you mark, and this gives you a point as described by Stager. And this is very effective for controlling a 4+ inferior oblique overaction. So it's a very simple surgery, doesn't have a problem in doing, and you can just get the conjunctiva back closed. The inferior oblique does change the fundus torsion. In coming to the superior oblique, we have several procedures. The tenotomies, temporal or nasal, both are out of my recommendation. Tenectomy also I would not like to recommend because of the risk of superior oblique palsy that may be created. Z or L tenotomy you may do. Posterior tenectomy or posterior tenotomies again can be done for mild to moderate superior oblique overactions. The anterior tenectomy has been talked about for correcting the torsion, weakening the torsion. And similarly, the differential recession of the anterior fibers is a newer procedure which has come up. The more commoner procedure, which nowadays I'm doing for a Brown syndrome to weaken the superior oblique, is a hangback loop tenotomy. The silicone expander also I have used earlier, but I find this puts a problem in that thing that you may have a fibrosis in that area. So I have stopped doing the silicone expander as much, and hangback loop tenotomy is a preferred procedure nowadays that I do. The posterior tenectomy and translational recessions, you have all seen them. They have been in the past done. The loop tenotomy, I'll just show you a video. Now this is the child requiring in a case in which there was a tight superior oblique. On abduction side, it's good. So you, again, as I said, we have to approach all the superior obliques from the temporal side. So it's a superior temporal incision that was made, and you hook the superior oblique. See, the superior oblique has been nicely hooked, and intramuscular septum on either side are dissected, and then the superior oblique is dissected free and held with the fixation forceps. Make it free so that it can be released fully. And then for this, I am using the 50 ethibond suture, non-absorbable suture. Make your FDT free. In a Brown's case, this you have to do it. And then you pass the sutures. This is an hang back. So it's an adjustable thing. Intraoperatively, you can hang back the amount of superior oblique lengthening that you want to create. This is, so wherever you put, you can go back and recheck if your FDT is fully taken care of or not. So once it is done, then you can close the conjunctiva. So this is much neater procedure than a chicken neck suture. And this is the post-op result. For superior oblique strengthening, we have been doing tucking, stenoplications, modified Harada Ito, and the classical Harada Ito. The choice, of course, is the modified Harada Ito. Because of short of time, I think I'll skip this part. Coming to the transpositions, there are several options which we can add on. Partial tendon BRT or a full tendon BRT, a single muscle SRT or IRT, as was just talked about by Shruti nicely. Augmentation by resection on these vertical rectors that we want to transport would be further adding the effect, or augmentation by Foster sutures may be also added. Augmentation also can be done by cross section, as we have described in partial VRTs also. And a plus effect can be got by antagonist medial rectus recession or the Botox, as again was shown by Shruti, and agonist LR plication can also be done. So these are several procedures. I'll just show you schematic diagram of the partial VRT. And this is very effective procedure. It corrects the marked esotropias in addition to the MR recession, which has been done in this case, and gives you a very good abduction, as you can see. And because we are using a partial VRT, we are having a control on the vertical deviations and also the torsions, which do occur. And even though Dr. Hunter's group may say that it is very little, but the later publications, they have admitted that it is there. So one can do that. Modified Nishida is a good procedure, which now we are finding more and more useful, because there is no disinsertion, no splitting, no risk of anterior segment ischemia. We are directly vectorizing the force through the sclera. I say this is like direct bank transfer technique when there is no pilferage from the middleman. So the middleman, which was there in Jensen's procedure, the paralyzed muscle itself is a procedure which should better avoided, because the effect may be lost in time. So modified Nishida is a very good procedure, and this is a vessel sparing surgery in a way, and this can be done. Coming to, I remember Dr. Joseph Deemer took a very nice lecture on sagging eye and the heavy eye. So using the technique of modified Nishida, I have changed the technique for the SR-LR loop myopexy, and it's now relatively easier that I would do. Bilateral MR recession if the FDT is tight for MR, and the loop myopexy is shown in this video, which you can see. This is a superior temporal incision, fornix incision made. The superior rectus is being hooked. The important part is that you need to separate the intramuscular septum on the nasal side so that the superior rectus is totally free to move. Otherwise, your effect is not good. So this is what has been done, and you can mark it 8 to 10 mm from the insertion. You don't have to go 14, 16 mm as originally described, because even this works pretty well. And 50 ethibond sutures are passed, imbricated into the superior rectus. You can have full width transfer, and you can have more if you have a large nasalization of the superior rectus. And then you bring it closer to the superior rectus, mark it at the same point, pass it into the sclera. So it's important that we also imbricate the sclera with these sutures, and then pass it into the muscle again. Now this is what is important, that the superior rectus is very nicely displaced on the lateral side. And once this is done, then I will pass it into the lateral rectus. The lateral rectus relatively is more easy to maneuver. So you can pass these two sutures back into the lateral rectus and then tighten your sutures. this way. Both these sutures. Yeah. So I would just complete this, and this is how we can just finish with this. And these have been talked about by Dr. Shruti. I may not go into the details of this. And the targeted strabismus surgery is what we talk about. Just a note about Kenneth Wright's procedure of a mini tenotomy, which is a post-op 3 to 4 millimeter cut shown. It corrects about 2 to 4 prism diopters by him. I have never tried because this is too small a correction that we may be targeting. Similarly, a mini plication is going to correct about 5 to 7 prism diopters, and this may be a procedure which one may try. I have never tried. The other procedures which have been coming on the horizon are the superior oblique tendon sheet stripping, repair of the IR flap tears, muscle transplantation, the resected segment lengthening, anterior tenectomy of superior oblique, as I said, and a very unusual procedure for nystagmus, the Sinski's procedure, which should be better avoided. So I think I've just ended this talk that we have to be squintellectuals and plan our surgeries to restore the alignment. Thank you all.